much, and thank you for inviting me today. So, my name's Pete Gordon. I come from across the border. Come in peace. I have a father who is Welsh, a wife who is Welsh, so looking forward to this weekend. So what I've been asked to do is talk around about the Safer Patient Flow Bundle and Red and Green Days. I'm going to talk about that, but I'm going to talk about a few other things around urgent emergency care as well. And I'm also conscious that I met some of the Morriston team at the national event, so and I saw some of the really good work that was going on, which was great, and it was really, really good to see. And there's one thing about the Safer Patient Flow Bundle and Red and Green Days is to remember they're just tools. They're tools. Without the right approaches, attitudes and behaviours and culture, they remain as just tools. But the biggest thing I want to talk to you about is patient waiting, and the fact that patient waiting isn't passive, particularly for our frail older people. And that's going to be a consistent form, that's going to be a consistent message throughout the presentation. Is anybody on Twitter? Do you tweet? No, isn't it funny? You've got this group of, is that a matron uniform? So you've got you who's going, yeah, and you're like, I'd never do that. I'd never do that. That's just for losers. So I used to be you, and now I think I'm you. But for those of you who do tweet, these are good hashtags to follow. Hashtag home first, hashtag red to green, hashtag MPJ prices, hashtag safer. Now, some of you may not want to tweet, but actually what I found about Twitter was it was a great place to find information from. And I'm going to talk about things like NPJ paralysis a bit later on, because I know you've... I love these posters, by the way. Absolutely love these posters. They're different from anything I've seen anywhere else. Absolutely excellent. So just starting off when we talk around this type of stuff is we talk about... One of the big things for me is I can remember being a rather reluctant staff nurse and student nurse, and I trained as a nurse in the 1980s, which feels like a long time ago now. And I'm going to be honest with you, during my nursing career, when managers used to speak to me about performance targets, it didn't really get me. If I'm being really honest with you, it sort of turned me off. But what really did get me motivated was when people talked about stuff which was to do with patients. And I'm just going to run through a few facts fairly briefly. But a crowded emergency department, which basically means there's lots of waiting, has a direct correlation with increased mortality. There's 43, this is one study, 43% more deaths when emergency departments are crowded. That's an increase in 10-day mortality. So when you maybe have a crowded emergency department and you say, well, we're mitigating the risk, the bottom line, a crowded emergency department is unsafe, and that's unsafe for patients. But also crowded emergency departments, if you've got patients who've waited for extended lengths of time, over 12 hours, there's a significant increase in their length of stay, which, and this study is 2.35 days, but also a delay in people getting essential drugs. So this is a study, it's a little bit old now, but, for these people with community-acquired pneumonia, their delivery of intravenous antibiotics were essential for treatment. There's a delay there. But that's the ED, that's the front end. As we move towards downstream, which is where the Safer Patient Flow Bundle and Red and Green Days are focused, these are the things that really compelled me, if I'm being honest with you, is the fact that 48% of people over the age of 85 die within 1 year of hospital admission. 10 days in an acute or community hospital leads to the equivalent of 10 years ageing in the muscles of people over 80. And so a really good friend of mine, Brian Dolan, who's a visiting professor and likes to just jet set across the world, he coined the phrase, if you had 1,000 days left to live, how many of those would you choose to spend in an acute hospital, just waiting in a hospital bed? Which I always think, that gets you, it doesn't just get you here, but it gets you here and it gets you in your gut. But he also coined the phrase that patients' time is the greatest currency in healthcare. And if you really think about that, when we're prioritising things, that should beat everything else. Because remember, waiting isn't passive. So that should trump absolutely everything else as the main currency of healthcare. And then thinking about it, we often think about capacity as beds. I bet you lot chase around for beds all the time, don't you? Is that in your job description? I will chase beds and go home late as matrons. No. Well, capacity isn't beds. Do you know what capacity is? Do you know what beds are? Beds are places where patients wait. There's no randomised controlled trial for a bed. And I think back to when I trained as a nurse in the 1980s in the middle of Birmingham. We loved beds, and we had lots of them, and we'd get patients from a bed to the chair using the Australian lift. Does anybody remember that? Does anybody not remember it? Usually there's a young nurse somewhere in the audience and she or he's going, what's that? But yeah, beds are those places where patients wait, and I think about the mindset from maybe the 1980s to now. You wouldn't think that you could have a cholecystectomy as a day case. You wouldn't think that you'd be doing ambulatory emergency care. But we need to somehow get out of this. We do need beds, of course we need beds. But we, you know, you've got to think of them slightly differently, because patients come in, they get some care, and then they wait, and then their sleep is deprived. They're in a different environment. I often think about my mother and father here, and then they wait, and they get sleep deprived, and they get some care, and they wait. So it's just a key message. And when we think about this waiting period here, this is the, you know, these are the red days, aren't they? Which I guess you're sort of familiar with. So that message that waiting isn't passive. But this thing, you've got to connect here. So when I'm speaking to you, you'll probably think there's a bit of logic in what this bloke's saying. I get the time thing, but you've got to connect to it emotionally. You've got to feel it. Actually, this is what we're here for. And some of the silly rules, I'm going to talk about silly rules a bit later on. And as human beings, how we like to comply with that. But you've got to connect to it emotionally. I'm just going to put this picture up. I'm going to come back to this picture. This is my colleague Lisa, who's a member of the team I work in. She's also a nurse. But one of the things about the last 1,000 days is everybody in this room has a number above their head, and that's the number of days you have left to live. But what I'd ask you to do, just while you're watching this video, this very brief video, in the video there's a number of days which are above people's heads. There's two ladies who have the number 1,000 above their head. One's in a hospital bed, one's in a car coming home. You can imagine what she's coming home from. But just think about this. And what I'd ask you to do is, when you're watching it, is think about that frail older person that you know and maybe significant in your life. If that person was stuck in a hospital bed.
The day's almost over, the sky's about to show her the first glimpse of gold over waking up dreams. The thing is, I don't know why things that I felt so concerned with just let go, drift with the breeze. I've been running around looking for answers, and all of these days there still ain't enough. Like the moonlit late plains, let the questions just hang. All I need is time with your love. I've been running around looking for answers, and all of these days there still ain't enough. There ain't enough. Time with you, love. There ain't enough.
So time's important, and that's one of the messages to sort of get across, and hopefully that sort of, you know, pulls you in emotionally. But I talked about my colleague Lisa, and I interviewed Lisa for a job a while ago, and I hadn't really worked with her very much. And then during her interview, she told me this story. So this is Lisa on a wedding day. It's about a year and a half ago. She got married. This is her husband, who also works in the health service. And this is her father, who's called Richard Hood. And during the interview, she said that's the number he had above his head. So she went on a honeymoon, and she had a phone call from her mother who said, "Oh, your dad's been to the doctors, who was complaining about his knee, and the doctor spotted clubbing of his fingers, which is a possible symptom of lung cancer." Anyway, went to the doctors, and doctors confirmed it was lung cancer. And Lisa thought to herself, well, you know, he's a big man, he's pretty fit, he's got a chance. He may need radiotherapy and chemotherapy and some surgery, but he's got a chance. Anyway, so he had bloods taken and letters were sent. The bloods were lost. The results were misplaced, the letters were misplaced, so time went on, and eventually it said, well, he needs he needs a bed because he needs a biopsy-type procedure to work out the right course of treatment. So he turned up after all these delays, and on the first day, and he was in a gown, and there was no bed available. And then that happened day after day. Eventually, by the time he did get a bed, so remember, multiple weeks have transpired here, which then turned into months. Then he was inoperable, so he had to have palliative treatment. And, you know, he never accessed an acute hospital again after that. He accessed hospice care. But the thing that got me about Lisa is she said, what about if one person would have escalated one issue? What about if one person would have challenged, why do we accept patients waiting? What if one person had said, why are we waiting a week for an assessment for X, Y, and Z? What if one person? And she also said, the thing that got me is it wasn't about the patients in front of you. It was about all these patients everywhere. And Richard, her dad, was never seen again in terms of an acute hospital. So I just thought it's an important story. It illustrates the point. Time's important. You know, our job is to save patients' time. So why the Safer Patient Flow Bundle and Red to Green Days? Well, if I was to say to you, is putting a man on the moon the same in principle as raising a child? I have 4 children. I don't claim to be the best father in the world. In fact, as they get older, I wonder about my skills pretty regularly, especially with my 20-year-old. Just realised that this is being filmed, but never mind. But putting a man on the moon is complicated, and raising children is complex. So you can have very complicated rules to put a man on the moon, maybe big trajectories and equations and things like that. But with children, you sort of bring children up, you have to use simple rules. Urgent emergency care is a bit like that. For example, who's got children here? Would you use a Gantt chart for bringing your children up? No, it would be pretty silly. But you do use simple rules, and urgent and emergency care is a complex adaptive system. So simple rules work. If you try and overlay very complicated rules on top of urgent emergency care, it doesn't tend to work. So keep it really simple. As Albert Einstein said, if you can't explain it simply, you probably don't understand it well enough. And human beings generally like to overthink and overcomplicate things. And the Safer Patient Flow Bill and Red to Green Days are an attempt to simplify things. And where are they aimed? So if this is a hospital journey, that's maybe ED over there, ambulance handover, assessment units. It's aimed here. It's predominantly aimed at specialty wards. And I'll be honest, when I came up with Safer, it was predominantly aimed at medical inpatient wards. That's where it was aimed at. And the reason why is that's where the waiting from a patient's perspective, that's not the staff don't work hard, but that's from a patient's perspective where the waiting is most significant. Waiting is out in hours down there, yeah? Waiting is days and weeks here. Does that sound right? Yeah. But again, the health warning on this is don't performance manage this type of stuff. They're only tools. Without the right attitudes, behaviours, cultures, they won't work. For example, someone emailed me the other day and said, oh, we need a trajectory to reduce the number of red days. That is really, really silly because that's not the measure. Actually, if I had 10 wards in front of me and one was saying we've only got 2 red days this week and another ward said we've had 400 red days, I'd say the one with 400 red days is the one who's doing it properly. That's not the outcome measure, and I'm going to talk about measures. The thing about red and green days is it's about what are the things that are causing our patients to wait the most, and that's what it's about. But you've done some work on red and green days, yeah? Great. Okay, so I'm not going to go into it in too much detail. I'll probably talk around it a bit. So red day is a day when a patient receives little or no value-adding care. For example, if you do board rounds? Yeah, I knew that. Okay, so if I'm at the board round and you know, in the morning, Pete needs a chest X-ray. Yeah, I'll order that. Does the day go red or green? Green. So, yep. I'm going to, yeah, I'll order the chest X-ray. Will we turn the day green? No. Oh, you've been trained. Yeah, very good. When will it go? When will it go green? I'm going to focus on you guys just for this question.
When it's been done and seen.
Done and seen, yeah, and maybe a plan in the notes going forward. Very good, excellent. Yeah, so that's right. So all these things. Do you know what? If you translate it really, really simply, a red day is a day when not everything happens that should do. So it's a day when, you know, everything doesn't happen to perfect. Can I ask you one question? Do you dress patients here? I know you've got your campaign here. Do you routinely dress patients? Encourage them to get dressed, up and moving?
Yeah, we do.
Do you? Great. So if my dad's in your hospital and he can be dressed and up and moving, if he isn't, is that a red or a green day? It could be red. Do you know the big thing with red and green days is don't force the reasons on them. They should come from you guys, you guys, you guys as well. But that could be a red day, couldn't it? If you're going to really, really go for it. So yeah, so a red day is a day when not everything happens that should do. I'll give you an example. My mum, this is my mum, this is my dad, and my mum went in for an operation in Birmingham on her back. EDD was Friday. It's all good. Mum, you need to get up and walking. You also need to get dressed. And went to pick her up on the Friday, and the staff nurse said to me, she's going to have to stay in because I don't know if you know, but she's got AF. I said, I really know she's got AF. She's had it for about 10 years. And the doctor wants her to stay. And I said, well, can I speak to the doctor? So I spoke to the doctor, registrar, and he said, your mum's got AF. I said, well, I know she's got AF. I didn't play the nurse card or the I'm working the health service card. And they said, we're going to keep her in over the weekend to monitor her INR levels. I was like, she really doesn't need to stay in this hospital for her INR levels. We'd like to do it. We think that's the safest thing to do. Now, I'm a pretty persuasive sort of chap. Could I get her out of there? Absolutely. I said, are you short of beds ever around here? They went, we are always short of beds. So, well, I could take her now. I could take her now, and I live 55 miles away. Yeah, we're going to keep her in. Okay, all right. What time on Monday should I pick her up? Because I'm going to phone my brother Michael, and he can come down from Manchester. I can pick her up at 11 o'clock. No, not 11 o'clock. The way we're going to do is she can have a ward round on Monday. I'm like, but she could go now. Yeah, she's going to have a ward round on Monday, and then what they do is the junior doctors will go off, and then they'll come back, and then they'll write her medications up. So why don't you come in for 3 o'clock? Okay, I'll come back in for, my brother will come back at 3 o'clock. What time do you think she left? All right, guys. Actually, it wasn't as bad as 8 o'clock, but it was 5:30. But my wife went there, who is a practicing ward sister, who's also quite persuasive. And then we brought my mum, who's recently moved to live close to us. But they're just those days over the weekend and the Monday, Saturday, Sunday, Monday. Were they red or green? They're deep red. They're bleeding red, aren't they? I mean, but they're the type of things in most hospitals. They do have, everyone goes, oh, everything's external. That was just a very, very simple and resolvable thing. Now, some of you may have seen the video. This is a video which has got, this is Ian Sturgis, who used to work with us, and he tends to work all sorts of places now. He's a geriatrician. But this just runs through red to green in a bit more detail. I'm conscious some of you may have seen it, but for those of you who haven't, it's quite a good reminder just to talk about red and green days. So, those videos, that video's very easily accessible on YouTube. Just building on the red and green day principle is one of the things that seems to be a common theme is do patients and their loved ones, are they well informed enough? And so we'd say these are 4 questions which every patient and their loved one should know. And in our experience is there's a real gap between what patients you think they might know and what they don't know. And the trick to do is to look at your complaints, which are usually the tip of the iceberg. But the questions are this: do I know what is wrong with me or what is being excluded, which requires a competent senior assessment and discussion? Do I know what is going to happen to me now, later today and tomorrow to get me sorted? What are the things you're going to do, and can you explain them to me in my language? If you say you're going to have a CTPA, Pete, I don't know what that means. Is that painful? Is it hot? Is it cold? Is that an operation? What is it? Just speak to me in my language. But also, what do I need to achieve to get home? Me, myself. And that's the clinical criteria for discharge, which can be a combination of physiological and functional parameters. Do you use the term back to baseline? Don't worry, you won't be punished if you do. But is that something which you use a little bit or not? They just said they used it a little bit. So just that no, not really. No, that's great. That's really, really good. Just some places still use it, but it's, for example, if I have an appendectomy today, how long will it take me to get back to baseline? Probably 3 months, something like that. So I can run, I don't know, 10 miles again or something like that. So it's really a useful phrase. And then the fourth question is, if my recovery is ideal and there's no unnecessary waiting, when should I expect to go home? The EDD. One of the things when you're thinking about red and green days, maybe when you're doing your board rounds, a simple thing in the morning is are we assured, are we really convinced that our patients and their loved ones, can they answer these questions? Have any of you sat next to a bedside with a frail older person as a visitor? Have you always felt that you've been informed about it? It doesn't need to be in this hospital. Yeah, when I remember I was in hospital not in hospital, I was visiting my aunt who's my father's sister. I was desperate to know the answer to these questions, and so was my cousin. And so you could take these and put them into the hands of many people. So, for example, you know, if I'm a HCA and I'm on one of your wards, I could quite easily say to the patient, do you know what, this is what's going to happen today. We're going to walk you to the bathroom or the shower room. You're going to have a wash. You're going to get dressed. You're not going to use the commode once today. You're going to have a test this afternoon. I could do that as HA, couldn't I? You could put these questions in the hands of many. You know, the best way of testing out to see if your patients know about them, use the patient public representatives. You've probably got people who are willing to help here, have you? Get them to come in and just randomly visit once or twice a couple of wards and play the results back to you, and then see to yourself, do our patients and our visitors and their loved ones really know? I'd say, remember, lots of red days aren't a bad thing. If your patients and their loved ones can't answer these questions, you've got an opportunity for improvement. It's not about punishing people, opportunity. And if you implemented these widely, my hypothesis would be that your number of complaints would go down. Can I ask you a number, just in terms of complaints around discharge, is there a theme around it? It was all last minute, ever? Does that come through? It usually is, but what I'm saying to you is these questions, you can adapt them, some places do, but they provide an opportunity. If I'm in your bed, my expectation is really simple. I would want to know the answer to these questions. Some practical tips. So red to green, Safe Patient Flow Bundle comes from us as a team, but these are some really practical tips. Board round in the morning, you do board rounds, we said that. Start every day as red and don't turn them green until all the actions have been completed. Develop a local set of reasons. What people like to do is develop a very corporate set of reasons and say, these are the reasons. Me, I'd probably let wards experiment a little bit with them, because then they feel a bit of ownership there. So reasons could be, if you haven't got a senior decision maker at the board round, if you're waiting days and days for assessments. So we heard a couple of stories at the last session. But what are the time standards for various interventions? Do you have internal professional standards? How long is it acceptable to wait for a CT scan on the ward? But it won't be a judgment, it's just like, what's the rule?
Depending on this emergency, it'll be straight away.
Straight away for an emergency. What about if it's routine?
2 days, that would be within the range.
Is that the agreed standard?
Yeah,
we haven't got an agreed standard.
Okay, so it's not. Do you know what? There's absolutely no judgments from me. So they're the type of things. You see, you're all obviously very motivated. I can see this isn't new to you, but actually that's the type of thing you say. Well, what's the standard? You're from radiology. Great. Our experience of this is, do you know, the best thing to do is typically get people to just have a conversation with each other. One hospital we were at, the specialty doctors were saying 24 hours is okay for a plain x-ray or something. And what we did is we got them to have a chat with the radiologists and radiographers, and they went, you're joking, aren't you? We can do that in about 12 hours or 10 hours. So to have a conversation, to get those standards. There's something about really challenging and asking, does this patient really need to be in a hospital, acute hospital setting? So every day think to yourself, what is stopping this patient going home? Why not home now? Why not home today? So for example, if you're keeping someone in just for IV therapy, for TDS intravenous therapy, Is that a red or a green day? If that's the only thing you're keeping them in for? Yeah, it's a red day, irrelevant of whether the service is there, because that service should be there. From a patient's point of view, keeping me in just for TDS, IV antibiotics in this day and age, it's a red day if I don't need to be in hospital. The 4 questions we've talked about, and then the other thing that really seems to work is an afternoon huddle. And that doesn't need the consultant there. It's a bit like the olden days of nursing with the big red book that Sister had. It's these things we said we'd do in the morning, have they actually happened? The number of things that fall through the net that don't happen is significant. And these things do need clinical buy-in. When I'm talking clinical there, I'm talking about doctors. And the language should be more about what's the opportunity for improvement rather, look, you're a terrible ward, you've got 50% red days or something like that. So it needs to be around improvement. I'm just going to play a video now. It's called The Mrs. Andrews Story. So this was put together by Professor David Oliver, who was previously the president of British Geriatric Society. He's vice president of Royal College of Physicians, previous colleague of ours. But he put this story together. This is a story of an old lady who fell at home. It's a very common story. What I'd like you to do is watch it and then count the number of green days this lady has. This is a very real story. There's a Mrs. Andrews in every single hospital. But count the number of green days and think to yourself what could have been different. So it's quite, Mrs. Andrews, I think it's quite a good depiction, isn't it? So most hospitals I've been to, it's not unusual. What did you think? What were your thoughts about the number of green days that Mrs. Andrews had? Just shout them out. There's not a right or wrong answer, guys. 1 or 2? Yeah, I mean, there was a few there, wasn't there? But there's probably about 2 or 3, something like that. If you really go through it and you just, I mean, that's been probably quite lenient on the green days. But if you go through it, there's an awful lot of waiting. And you saw what happened to her. Do you see the multiple bed moves? Do you know, and the outline? Do you know the evidence behind multiple bed moves but outliers? If you outlier a patient, the increased risk of mortality goes up significantly. So if, it goes up by about 50% based on some research in Scotland. So if your mortality rate is 2% and you outlie, it goes up to about 3%. So every time a patient's outlied, it's significant. But I think the biggest point there was the stuff there probably at the start of Mrs. Andrews' journey that could have been done, comprehensive geriatric assessment, maybe a big group of, therapists right at the front door, and maybe she could have had a length of stay of 2 or 3 days. But by the time she got downstream, all that deconditioning, significant. But that one, again, that video's available to play. I think that's quite a good one to illustrate the number of red and green days. Now, just a top tip, there is a requirement to track the red days, a bit like you saw at the hospital where the video was on. But don't get overburdened with tracking them. And I do speak to sort of the operational managers here, really. There sometimes can be a desire to over-manage and everything else. The key thing here is capture the reasons. The biggest thing that you want is on each and every ward is a knowing how you're doing board that is viewable to everybody, and it probably has 4 charts in it. One is a Pareto chart here on the right, and that is basically these are the top 5 things that are causing red days. That translates into these are the top 5 things that are causing our patients to wait. Remember, waiting isn't passive. So in this trust, it's specialty review, packages of care, diagnostics, therapy and equipment. But that needs to be at a ward level. And they are the things that we should focus our improvement efforts on. There's no point going a mile wide and an inch deep. Let's do everything. Do the things that are causing your biggest problem. Red to green is based on something called the theory of constraints. So it's about trying to reduce those things that are causing unnecessary waiting. So that would be one chart. And then maybe 3 other charts. One could be the number of stranded patients, but put them in the right format. So say, for example, Ian talked in that video about maybe testing it out properly on 2 or 3 wards, and it sounds like you've started to do that, but really know, are the things that you're doing, are they making a difference? So you could have stranded patients, median length of stay, percentage of patients who've gone home before midday. But that's measurement for improvement. That's not measurement for judgment. And if you want really good clinical engagement, our experience, we're a pretty clinically led team, so a lot of MD team members in the team, but quite a lot of doctors as well. If you use data in the right way, if you want to influence doctors, this is the right way to do it. Use things like statistical process control. And you know, a real test to know if this is embedded. So if you really want to know if it's embedded, the trick is to walk onto a ward and say to a junior doctor and a staff nurse, can you tell me how you're doing? If it's only the ward manager and maybe one of the consultants who can tell you how you're doing, you probably have still have an opportunity for it to embed and sustain. And remember, this stuff isn't easy to do. It sounds easy, simple rules, but it's quite hard. But that's a test. So the wards you're running, say from red to green, if you're an exec, you can walk on there, say to the staff nurse, tell us how you're doing. What percentage of patients go home before midday? Have you reduced length of stay? What are the top 3 things that cause patients to wait on this ward? And then the other thing with red and green days is if you have something which is an issue at a ward level, there needs to be a good process to escalate that issue. So I'm going to come out with it and say very early on, I don't believe in conference calls. I think they're quite a waste of time, actually. What do you think about that? I provoked the last group with this, but the thing is then they agreed with me. But actually, I'm not sure conference calls help anything.
No decision making in there, so in meetings, not add any value to it.
Yeah. So I just debate this type of stuff a lot, really. But one of the things that we do see quite a lot is this thing which we call escalitis. So everybody just passes stuff up the chain and go, we've got a problem. If you've got a genuine problem at a ward level, if you're a ward member of staff, is maybe a good approach to use is SBAR. Are you familiar with SBAR? Situation, background, assessment, recommendation. I can remember when we first used it when the critical care outreach services had been set up, and I can remember just thinking, actually, we're not communicating properly here. But if you've got a problem, say a red constraint that you can't deal with, is to use SBAR to communicate it upward. So it could be, you're my matron and I've got this problem, the situation is this, background this, but then also what I expect in return is to you communicate back to me using SBAR to tell me what you've done about it, because far too often we hear, I've told the COOP, I've told the director of nursing, I've told the medical director. So just to be aware of escalitis, because otherwise it just all goes into a sort of big melting pot of bleh. So that's red and green days. We're going to have a bit of a chance afterwards to have a conversation around that, maybe things that you can further test out on your journey. The Safer Patient Flow Bundle, so I'm aware that you've started some work on this. Just a quick background about this. This isn't, so it's always interesting. So you've got the document from the Welsh Government, which I have looked at, which is great, it's good. But the origination, the genesis of this bundle comes from someone with a nursing background, a Brummie bloke from Birmingham, and it's as simple as that. So a number of years ago, I can remember someone walking onto my unit and said, have you heard of the ventilator bundle? And I was like, no. And I said, are you clinical to this chap? He went, no. I thought to myself, loser. And that's what I thought at the time. I was next to my clinical colleague, and he said, well, why don't we listen? And then this guy said, oh, there's 4 or 5 things you do with the ventilator care bundle. I may get them wrong, but it's things like you sit the patient up at 30 to 45 degrees in the bed, you turn the sedation off, you protect their gut, and you protect them from VTE. And he said, and do you use measurement for improvement? So I went, yeah, use measurement for improvement. No idea what he's talking about. Anyway, he left. And then I went around the unit. What I found was the things I said I did, the things that my team said they did, they didn't do. So, and when I measured the angle of everyone's bed, no one was at 45 degrees. Not one patient. Not one patient had the sedation turned off. But there was me. I'd stood in the meeting, said, yeah, we do that. We hear it all the time. It's a human thing. So the Safer Patient Flow Bundle is based on the concept of a clinical care bundle. It's based on keeping things simple, and it's based on reducing variation. That's what it's based on. because variation is rife. There's 5 elements to it. The first element is a senior review. Every patient, every day, deserves a senior review. And that should preferably be by a consultant, but as a minimum, a registrar level every day. And that may take varying forms. It could be, preferably a face-to-face, and that doesn't mean a doctor by him or herself. And there is a bit of evidence behind this. This is a study which compares twice weekly, which is very old-fashioned these days, twice weekly consultant rounds, to twice daily, and the comparative effects of length of stay. But remember, those doctors do need support from multidisciplinary team members as well. And the other thing to consider testing out for senior review is a ward round checklist. And this is a considerative checklist to make sure stuff isn't missed out. Do you think that stuff is ever missed out on ward rounds? Yeah. Is this something ward rounds, or are they hallowed ground that you can't talk about? What percentage of nurses go on ward rounds?
Probably say about 50%.
50%. That's really good. If it's 50%, that's on all wards. No, that's not criticism, but having a checklist is because there could be, for example, you could be in a surgical ward and you could have 4 rounds going at the same time, unless you've got a nurse in charge who can split themselves into 4. But there does need to be something which is a good handover process. But it is worth testing out a ward round checklist, because human beings tend to miss stuff out. And the other thing is about this, you're trying to reduce the batching of tasks at the end of ward rounds, which inevitably lead to late discharges. And then the other concept to think about when you're thinking about ward rounds is, this is from Sweden, and this chap here, if you look, Google wardrounds.net, they do 70 to 80% of their ward rounds in the medical ward in the office. So think about that. Everyone goes, well, the patients couldn't walk to the office. Test it out. You could test it out on one ward. And do you see the level of patients at with the staff? I'm not looking down at a patient, they're at the same level. Have you got a ward you could test that out on? Okay. It may not be so relevant on a surgical ward, but it's a type of thing, test out from a patient's point of view. From a patient's point of view, you could test that with 1 or 2 patients, couldn't you? Yeah. Just test it out. I'm not saying that's a solution. I'm very impressed with that, because I think actually this thing where in the bed, what percentage of medical students do you think get trained on ward rounds in their training? So I'm only going on the figures that a consultant in Surrey and Sussex called Natalie King told me. About 20% of them actually get any training on ward rounds in their medical training. Doesn't sound right, does it? But it's such a crucial part of things. So that's the senior review. One of the questions I'd say to you is, at 1 o'clock every day, do you know how many patients haven't had a senior review? Just a question. So if that's a really important part of the bundle, how many patients haven't had a good senior review? The A of the bundle is that all patients have an expected discharge date and a clinical criteria for discharge. Or translated really simply, all patients have a plan that the multidisciplinary team know about, but also the patients and their loved ones know about. Now, if my parents have dementia, they still need to be communicated with, and also I do as well, if I'm the next of kin. That's really important. So every patient deserves a plan. So, for example, this is a plan that includes physiological and functional criteria. So remember, every patient deserves a plan. A plan costs nothing. This could be for a COPD patient. Treat with oxygen to maintain SATs of 88 to 92%. Nebulized bronchodilators. Continue oral prednisolone for follow-up with the acute respiratory service at home. Clinical criteria for discharge: able to maintain saturations without oxygen, able to manage to the toilet, able to mobilise 10 yards. EDD, 11 a.m, 4th of July. Does that plan sound complicated? Does it sound all right? Sounds all right, doesn't it? Sound all right? Do all your patients have a plan as good as that? Yeah. How much does that cost to do? That can't cost anything, can it? So the A of the bundle is that all patients have a plan, which includes those things. I think you could probably do that fairly quickly, couldn't you? Yeah. I remember when my dad was admitted to hospital, he had an asystolic standstill, and I turned up at the hospital. I'd been working away, and I got there and I persuaded the agency nurse to look at his notes, and I looked for a plan that looked like this, and I found nothing of any value. How do you think that makes you feel? It makes you feel distraught. It makes you feel absolutely distraught. Every patient deserves a plan. And also, you know, can every patient answer those 4 questions? The F of the bundle is predominantly aimed at medical wards that routinely have patients transferred from the acute medical unit. This isn't research-based. This has just been tested many, many times. Those wards that routinely have patients from AMU pull their first patient before 10 o'clock. Before 10 o'clock every day, routinely, not just in terms of escalation. The trick about this is to let the wards pick it themselves. So if I'm the respiratory ward manager, my only job is to pull the first patient every day before 10 o'clock. Anyone who thinks that's unsafe probably needs to look at the flow of patients through a hospital. So how many patients have you got? How many wards have you got on here that would routinely have patients from AMU every day? How many medical wards would pull from AMU?
Some medical wards would, depending on the specialty.
How many wards approximately? 5? What about if all of those wards this morning had pulled a patient before 10 o'clock? Would that have made a difference? Yeah. Yeah. That's a trick. That's something you can test out very quickly. That will help decongest ED. But it also, site management needs to move to one side on this. All I need to do is make sure it's happened. The trick is let the staff pick the patient, but you have to pick a patient. So this is from a colleague, Dr. Gordon Caldwell, who's very avid and active on Twitter, but he has his team's scheduled discharges for 9 a.m. every day. Then his nurses, not his nurses, that sounds very old-fashioned, doesn't it? The nurses pull from AMU. But sometimes that doesn't happen. So he's got really, really good results for his discharge times. These are his discharge times. He gets between 30 and 50% of his discharges out. Complex medical ward before midday. But if you go back to here, I just realised it's being filmed. This is one of his emails the other day. 4 empty beds at 10 to 7 in the evening, and they have been empty most of the day after strenuous efforts again to do early discharges, e.g. F1 dropping off rounds to do discharge summaries. So creating the empty beds, but the empty beds stay empty. Yet that organisation probably could have done with those patients being transferred. So that's the F of the bundle. You could test that out. The trick is empowering the wards. The E of the bundle is early discharge, and I've just talked about Gordon. One of his big things is you've got to slow down to speed up. So especially if it's on a medical ward with complex patients, if you do every element of the safer patient flow bundle every day, 30% plus, this isn't holding patients back for the next day, is possible. What percentage of patients leave the wards here on this site every week before midday? 22%. 22%. That's not bad. That's not bad. Most places about 15 to 17%. You could get that up. 30%. I mean, other things as well. Do you have criteria-led discharge? What percentage of your patients would be discharged using criteria? So did you say yes?
Yes.
There's typically an opportunity with criteria-led discharge. So here's an example from Nottingham, and having been involved in this type of stuff quite strongly, the trick to criteria-led discharge is trust. So that's trust across teams. Have you got a day surgery ward here? Day surgery ward? Yeah. Who discharges the patients on there?
Yeah, the nurses do it.
Yeah, the nurses will do it. Is that your patch? Yeah, so the nurses will do it. And if you said to them, well, where's the governance or the special procedure to discharge patients on a day surgery ward, do you know what they'll say? Just the way we do it. We've always done it like that. We work pretty closely with the anaesthetists and the surgeons. We just discharge patients. I'll tell you a story. My wife's sister on a day surgery ward, which has escalation patients on it. And they had a patient which was transferred down. The patients they transferred down are near to discharge. It was a woman who's probably about my age. Her husband had come in and said, well, I'd like to pick up at 9 o'clock tomorrow morning. The agency nurse said, well, I'm not sure. She'll be ready then. So Karen and her mate Sean said, well, we discharged on day surgery ward. It wasn't so there's one bay here, one bay here. So do you know what they did with the woman? They wheeled her over here, right? So it's like 2 metres away. Then they wrote a discharge thing, and they said to the husband, yeah, pick her up at 9 o'clock, she'll be fine. We've done her TTOs, da-di-da-di-da. It's a silly story, isn't it? But you can see how silly rules sometimes don't work in terms of patients. Criteria-led discharge, I think you're right talking about the weekend. I think a big opportunity there. Biggest thing, so when we've looked at this, is trust between teams. You probably need a pro forma of something and probably some security for the nurses or therapists who are discharging. So if something does go wrong, they can either phone a consultant or access a hot clinic or something like that. But it sounds like you're doing some work on it, but this isn't modern stuff. This is stuff you could really take forward. It's not even pushing boundaries. And then a pharmacist, any pharmacists in the room? Pharmacists? The lone pharmacist. I think pharmacists are a group which add a huge amount to patient flow. So this is an example of a dedicated ward pharmacist in East Lancashire. So they have a pharmacist on every single ward round with a computer on wheels. And what they've found is their error rate has gone down. Pharmacists don't have to work over. Their discharge times have gone up, but also it's had a significant effect on length of stay. So, you know, in terms of this getting early discharge and other things, the use of pharmacists are, I would say, that's worth looking at. Now, when we're talking about early, the E and the F of the bundle, why are we really talking about them that much? That blue line there is emergency admissions. That pink line there is discharges. Do your discharges peak at tea time? Or later?
Sometimes on surgery, if they've had their date surgery, they've gone on the same day. They discharge in the evening rather than the next day.
Yeah, no, do you know what? Never keep them to the next day. Never keep them to the next day. That's why really the target's around set at about 30%. And the biggest constraint is typically the tablets and the letter. But that pink one, as a trust, probably reflects your bulk of discharges later in the day. And everyone goes, well, that's interesting. Do you know the big one there is the yellow line? So if that blue line and the pink line are out of sync, think about this yellow line, which is patients moving. So when did the last patient move to get into a bed last night? Well, from anywhere. It could be a transfer from AMU to a ward.
I probably heard the transfer at 9 o'clock.
9 o'clock, any later?
Probably later. It's just a patient going home and then I'm transferred it from next
Okay. It would be worth looking at that. So that's, if it's 9 o'clock, that's very different from Singleton.
That's because we've had patients who've gone on the day of surgery and we've had bed then, so
Okay.
we've been transferred.
So it sounds like on surgery you probably, you've got some patients going later down. Talking generally across the hospital, have you got patients still moving in the early hours of the morning?
Generally not medicine, because the beds are usually full.
Are they?
Generally enough, there will be an evening.
I would say on average there's about 5 patients from ED in the early hours.
Yeah. So if you crack the F, if you've got about 5, if you crack the F of the bundle, which is the early pulling, which the F pushes the E, it's worth measuring that because you could reduce that slightly. Because patients moving around the hospital, even if it's just 5, some hospitals have many, many patients. That is significant. I always think is that, you know, if that were my mum or father being transferred late at night, is incredibly poor practice. It's like pushing someone into a darkened cupboard. So that's the E and the F of the.
We've done quite a lot of work on earlier. We've been running sort of weekly awards for.
Oh, have you?
Discharge before lunch, etc. I think a lot of those 5 relate to areas where we got 3-session days, so we plan to have late discharges, and therefore capacity comes in later, occasional patient deaths. And it's rarely, and then sometimes in the medicine there's post-take ward runs that go on, and we have unexpected late discharges following that. But usually the beds that come up after midnight are not ones that are things that we could have done anything with. I'm not saying always, but
Okay.
we know really by sort of 11 o'clock that's more or less it, give or take 5 beds.
It would be worth looking at. it would be worth looking at because, in my experience, until you really look at it carefully, you may not 100% know. It'd be worth looking at all those transfers out. Bottom line is a transfer after hours when less people are there, when you've got bank and agency staff. The reason for the F is, and I'll be honest with you, creation by myself is to start the pull early in the day when people are around. Even if it means you go over for a short period of time, as long as things are risk assessed. The R of the bundle is the review of stranded patients. So patients have been in hospital for 6 days or more. You may choose 10 days, but this is a letter from a trust which use this as their springboard to do something about it. So dear sir, so this is from a patient in a bed who made a complaint to the chief executive from his bed. Dear sir or madam, this is a request for an immediate discharge from this hospital as soon as possible. The reason being that I feel the process of discharge is taking too long and I wish to leave the hospital as soon as it's possible. If the request is refused, then I will take it upon myself to walk out of the hospital. Yours sincerely. And they use that, but you know, most hospitals will have some patients who are just waiting. The majority of patients won't complain if you say you're going home today. The majority of patients, especially if you use the 4 questions. And when you're thinking about this is a fairly recent study published by Newton Europe, which is some work which was done in the north of England. Some of the headline findings from this study: 39% of delayed patients could have benefited from a different pathway decision. 36% of delayed patients were found to be waiting for a decision to be made on their discharge pathway. 60% of assessments and or therapy could have been taken place out of the hospital. The remaining 40% could have been completed in parallel with other steps. Good document, worth reading. We could forward that round to you, but this is the sort of ambition, is everybody to think home first. You know, because doing long-term assessments in an acute hospital, do you still do long-term? So I know sort of the answer from the trust, not the trust, the site I've just done. Do you still do DSTs and CHCs in the acute hospital? Yep. Yep. Do we think they create waiting? Yes. Yeah. So just remember, so you're not going to solve all the problems today, but that type of waiting, assessing someone's long-term care needs in an acute hospital, really does take up an awful lot of time. But it's not just that. So it's not about patient flow, but it's causing extra waiting. Do you remember the evidence I showed you at the beginning about those days in hospital, what they do for the physical deconditioning of patients' muscles? How long does it, on average, say if I need and those things, do they happen in parallel or sequentially? So what I mean, do you have to wait for someone's medically fit, then they do this, then they do this? Maybe a variety. A variety. Are you from the integrated discharge team or? Discharge liaison, yeah. So one of the things that when you're thinking about SAFE and you're thinking about the R of the bundle is to move towards this model where you don't do these long-term assessments in acute care and you move to a model of trusted assessment. Is that one of your plans to do? Yes. Good. And you know what, we'll talk about that afterwards. You know, one of the ways to test these things out is if you've got some wards where you're testing this stuff out, use them exemplar wards, get people, do the big room approach, get a big group of people, including social care staff and the discharge team together, start testing it out on one patient and actively break a few of the perceived rules. Actively break them. Because you don't need, how many DSTs do you do a week in the hospital?
There's a lesser amount than we used to do.
Okay, so it's coming down.
It is coming down because some of the approaches to assessment have changed.
Yeah. That's not picking on your team, by the way. These things are all interrelated.
I think the link of social care is critical level. We have done pilots on our old person's ward where there's about 7 patients now that we would have been having quite high package care or residential placements that we took over for tests to change. And actually the level of care those patients actually required was far less. It would have been, and also we've had bridging through our DCAS team at home that would have gone into 4 double-handed call. And actually the level of care people have needed is different. The problem we've got is the capacity within the sector to actually make that happen in a meaningful way. But actually that will create capacity because patients are not going to have over-prescribed social care.
Yeah.
But we're really struggling with getting engagement across the health and social care sector in relation to taking that the next step. So we've done the tests, we've got the evidence, we know it works. We just cannot get the commitment at a senior level within the local authority to really get some traction behind this.
I mean, that really, if you're doing the red and green days properly, that would flush out with your Pareto charts, and then that should be a whole system conversation. So it sounds like you've started to make progress on that. My experience of this, though, the home first mindset needs to be everywhere. It needs to be everywhere, you know. Why not home today? And the other thing with the stranded patients is internally is probably to think about doing a bit of peer-to-peer review. So this could be I'm on one ward and you're on another ward, me, a doctor, a therapist. We could just go and review each other's wards with these patients with slightly extended lengths of stay. And, you know, on each ward, just ask some simple questions. Is the patient sick enough to need to remain in hospital? And evidence it. So just because I say so is not a reason to keep someone in hospital. And if they're not sick, what has been done to get them out? But what could and should have been done on days 1 to 6? Because most days in acute hospitals, it's like we need to get discharges today. But of course, there was these previous days. You saw that in Mrs. Andrews. On her last day, on day 19, I bet there was a thing, right, discharge today, Mrs. Andrews, good, is she going? And what people forget is all those other days before when she was moved wards and so on and so forth. So this sort of type of approach, you could test on a couple of wards, couldn't you? But this isn't something like a length of stay meeting. This is something which is voluntary between clinical teams. And it's like me sort of saying to you, actually, let's just give it a go and let's see what the learning is. But one of the things that when we've seen this done really, really well is the number of stranded patients come down. So this is a trust which is using SAFE from red to green, but also using peer review for the R of the bundle. So if you look at the number of stranded patients, which is the blue line, you know, it starts at 300 and it's coming down below 200. But that is predominantly through internal processes, not due to external factors. Predominantly that is by doing the good stuff, thinking home first. Because when you do red to green really, really well in an acute hospital, do you think there's more internal or external reasons? Yeah, slightly more internal. It varies, so there's not an exact science. But so that's something you could test out. So it sounds like you've got the language of improvement going on and those type of things. You could think about, we have a conversation at the end, testing out peer review. This is my son, Alfie. I've got 4 boys. This is my third son, who's 16. He looks normal, doesn't he? He's not. He left us when he was 9, so he's got severe autism and severe special needs. So the reason why I'm putting up is not to say, look at him, he's a bit of a spotty 16-year-old. He's the most complex person I know in this planet. I've never met anyone in an acute hospital who has more complex needs than him. He's now 2 to 1. For a period of time, he was 4 to 1. That's 4 people, 24/7. If he's in your hospital, you will get him out quickly. I've never seen less waiting when he's there because he destroys it. He is, you know, but so he's now in his 4th placement. But the reason I'm not presenting it for pity or anything, but having seen him and been on the other side as a father and watch what works, is his placement now. He has something called a team around the child. They call it TAC. The reason why it works is the carers who look after him 24/7, and he's got various carers who are his favourite. They are in the meeting. Then you've got some therapists in the meeting, some psychologists in the meeting, social worker in the meeting, his advocate in the meeting. You've got me, his mum in the meeting. When you have this team around the child, even with the most complex patients, you tend to be able to improve it. And the reason I put up there is everyone goes, our patients are highly complex. You know, so I was in a London trust, they went, we're a bit different here, we've got a lot of old people. It's like, yeah, okay. You know, but the reason I put him up there is there will be a way of making it slightly better. His life, he'll always need 2 to 1 care. I hope he doesn't go up to 4 to 1 care, and the things that happen to him happen to other children, because, you know, it's immensely distressing. He can't talk. He can be incredibly violent. he assaulted a social worker recently and took a chunk of her ear off, which has to be surgically sewn back on. So in terms of complexity, what I'm saying to you is there's always something, but the trick is wrapping the care around the person and really thinking about that person, no matter how complex they are. I think it's important to implement all 5. Now, it sounds like you started the journey, guys, and I saw Khan and the team, who are incredibly the most motivated team at the national conference. I mean, their enthusiasm from the Morriston team was off the scale, which is great. But there will be stuff you can do to add to what you've done so far, but it's important to do all 5 elements, not just the ones that are easier. Have you heard of I know you've heard of it. I don't know why I'm asking this question, because I've seen these wacky posters here, which I love. End pajama paralysis. Heard of that? So this is just an example. What I'm going to talk a bit about now is how do you create, because you're going to talk about, we can talk about improvement, how do you create a bit of a social movement? Do you know where this started from? So you'd have heard of someone called Brian Dolan, who's a bit of a mate of mine, not a bit of a mate, if I'm being funny. Hello, Brian. But there was 4 of us, basically 4 people with nursing backgrounds, him and Anne-Marie Riley, my colleague Tim Gillett. And, the thought of getting patients up, dressed and moving has been around for ages. Therapists have talked about it, geriatricians. In the olden days, nurses talked about it. Your community nurse is still talking about it. But we thought we'd sort of start a campaign with no planning whatsoever, just a bit of enthusiasm. But it shows you what's possible. And the reason for the campaign is not just getting them dressed, it's getting them dressed, getting them moving. And you know what? You don't need to have a referral for OT and PT to do this. Anybody can sit a patient out of bed. Anybody can help a patient walk. I can guarantee you, I mean, we've got quite a few therapists in the team now, one of whom is called Liz Sargent, who's my mentor on this type of stuff and regularly tells me off about stuff. But she'd say you're not going to get a therapist telling you off, a HCA, staff nurse, anyone, for getting a patient out of bed and walking them. You don't need OTPT. I heard the words washing and dressing assessment this morning. These type of things you don't need. For example, kitchen assessments. If you get my parents to do a kitchen assessment, you don't do kitchen assessments, do you? In the hospital? Yeah. So if my mum and dad are in your hospital and you say we're doing a kitchen assessment, I will absolutely categorically say no. Do you understand that? Why will I say no? Yeah, it doesn't look anything like my mum and dad's kitchen. Yeah, you can stop that, I think. But the point is there, not about kitchen assessment. The point is there is, you're all therapists at the back, yeah? Do you have referrals for OTPT? Yeah, look, this is common, so this isn't about Morriston Hospital. What would you like people to do? Would you like the rest of the team to, if they can get people up, dressed and moving, would you like them to do that? Yeah, okay. And you know what? Our experience of it is actually, if you just get a bit of social movement, a bit of communication about this, most HCAs will do it easily with a bit of enthusiasm. It's just, this is what we do in this ward. If you can be dressed, you will be dressed and up and moving. Remember, at the moment, it's a social norm for people to strip off when they come into hospital. And that's it. I mean, people love to strip off. I'm in hospital now. Pass me my dressing gown, love. I'm going into hospital. Could you buy me a pair of pyjamas? You know, that's what I would have to say if I was going to hospital. So think about that, because these risks of habitual deconditioning are significant. You know, day 1, 24 hours, 2 to 5% of muscle power you can lose. 7 days, 5 to 10%. But how many times do you see a hypostatic or a hospital-acquired pneumonia at 7 days? Because people haven't moved, because of the things we didn't do. And this isn't anything new. Dr. Asher talked about this in 1947. Teach us to live that we may dread a necessary time in bed. Get people up and we may save our patients from an early grave. This isn't a new thing. So you may have started with go to town on it. And I tell you what, I said to the last group, if I was to come back in a month's time and say to your therapists, are you getting less referrals for OT, PT? They should say yes, because that's something in all of your hands. You could get more patients up and dressed and moving, yeah? And maybe think about stopping the kitchen assessments. That's not just a therapist, guys. We're going to stop the OTPT thing. Maybe think about that before we say we're going to do a kitchen assessment. What do you think? Give it a go? Yeah. Will you all stand up a sec? And will you just take 10 steps this way? And then 10 steps back to where you came from and sit down. So back the same way. So Chris, you decided to walk up the stairs.
I did.
Yeah, there's always one. So guys, the point there was this really, is a number of people have put pedometers on patients. Some of your patients this weekend, that's the number of steps they'll walk when they're in hospital. That's the number of steps they'll walk in hospital. You're not going to have this line of people up there. Think about if you could double those steps, treble those steps. But I don't know, have any of you had the flu recently? Yeah. Has anyone ever had it? Have you ever felt when you've really had to go to bed for a week or so? Have you felt your muscles decondition? Yeah. Now, don't imagine you've got frailty as well on top of it. This is why you've got to link all these things together. I'm not going to talk about that one. I can do. One of the things that is very inherent with human beings is people following silly rules. So you probably have some silly rules. So I know that I've abided by many silly rules in my time. But what I've got a video to play for you, and it's people can be like sheep. It's a real video, but it shows how people like to conform. And when you're watching it, have a think to yourself, have I ever been in a meeting or a situation at work where I've conformed to something which makes absolutely no sense and then just gone along with it? Would any of you ever do that? No, not me, not me. But it's that thing about conformity. So conformity can be a good thing when you want people to do the sensible stuff. But it reminds me of some jobs I've done before where I've been in meetings and I've just agreed to really stupid stuff. I've gone, oh, yeah, that's a good idea. And it's just ridiculously stupid. So I think one of the things, the reason playing that is to be aware that you may be going along with some stuff which has been there for a while, which doesn't make that much sense. I don't know what that is. Can you think of any examples? One of the things when we're thinking about this type of stuff is, and probably having conference calls in my head at this point of time, is rather than thinking like a firefighter, we've got a problem, let's have more conference calls, is try thinking a bit more like a farmer. So what does a farmer do? A farmer doesn't shout at the crops because, there's no point blaming the crops that they're not growing fast enough. A farmer doesn't uproot the crops before they haven't had a chance to grow. They choose the best plants and processes for the soil. They irrigate and fertilise, which is providing motivation. They remove weeds and obstacles, which is all those red reasons. And they realise that outcomes are not predictable. Sacking the farmer won't help the crops grow. So just have the key there is think more like a farmer than a firefighter. So most days we've almost got into a cyclical spiral of actually it's all about today. That probably won't alter things going forward. And if we want people to take action, real action, it has to connect with them. And so Marshall Gans is one of the world leaders around social movement. And rather than having a very clever advanced project initiation document, this stuff that captures people's emotions, it's not just your emotions as leaders, because most of you have been in leadership positions, that's why you're here, but the people also out there working night shifts and so on and so forth. If you want them to really engage, they have to feel it. That's why things like the last 1,000 days, NPJ paralysis. NPJ paralysis, what we saw when we launched it, remember we didn't even officially launch it, we just saw people spontaneously getting dressed around the country and so on and so forth. Do you know why? Because they got it, they understood it. So it's really important. If Martin Luther King was standing on that stage, one of the greatest leaders of all time, he wouldn't have said, I have a plan, a project initiation document and a trajectory, would he? What did he say? Yeah, he said, I have a dream. I'm not saying, because you're going to start thinking I'm really wacky, but you wouldn't say tomorrow, I have a dream. But what was he doing there?
Tapping into emotions.
Absolutely tapping into emotions. That, when I said, what did he say? You all went, he said, I have a dream. So, you know, for when you're a lead, if you go, look, our next big strategic plan is the OBC triangulated with the LBC into the INT. You know what that sounds like to a normal person? I think to my wife who's a Band 6 sister, yeah, that's what it sounds like. So just think about that when you're trying to create some movements. And then when we're thinking about the people who are most effective, the least effective people are these people, the lone wolves. And they typically go, I. So it's more about the people who say we. And those people are people like the mobilisers. They mobilise people by being able to call on large numbers of people to contribute and engage. And the organisers, these are people that build power by growing leaders, identify and recruiting and training future leaders, and they create a network of people. These are the people who are good at this stuff. And they're not always people who are in leadership positions. These are the people who are most effective. If you're in a leadership position, the best jobs I've ever done is when my leaders have spotted I'm quite good at these type of things. The worst jobs I've done is when I've been managed by a lone wolf who said, no, we really don't want you to do that. We want you to do this, and this, and we don't want you to think. So it's just to be clear, lone wolves are absolutely rubbish at this type of stuff. But you want to create the network. And also there's some pretty compelling evidence around something, you know, civility. So this is some work of Dr. Chris Turner, who's an ED consultant from UHCW in Coventry. And he started some really good work at Civility Saves. And when he says, when we permit rudeness, our patients die unnecessarily. And this is he came to one of our team meetings and presented. It had quite a profound effect on me and my wife-in-law. I call her my wife-in-law. She's a clinical director. I work with Dr. Jyoti Nupani. But this is what Chris said. 80% when you have a lack of civility at work, lose time worrying about this. 78% reduce their commitment to work. 63% lose time avoiding the offender, the person who wasn't civil to me. 48% reduce their time at work. 38% reduce the quality of their work deliberately because people have lacked civility. 25% take it out on customers or patients, and 12% leave. So the thing about being civil, you don't have to like me. You don't have to like me. You can think I'm an opinionated brummie, you know, who supports the villa, you know, da-da-da-da-da. Doesn't matter. But you can be civil to me. You can be civil to me. And that's a really important part of this whole stuff, is being really, really civil to people. And as well as that, you know, civility is actually just being nice. Now, you know, if you put that in some great project initiation document, next work stream, being nice to people, people would probably laugh you out of the world. But when Google did years of intensive analysis on this, what they discovered that the key to really high-performing teams that deliver change is the key factor is being nice to people. Think about it. When you go for your meal tonight, yeah, and you go to a restaurant, the first waiter who comes up to you goes, all right, yeah, all right, over there, you go, yeah, table for two, yeah, table over there, yeah, all right. Yeah, here's your food. What did you want to drink? Yeah, that's the first waiter, yeah. And then the second waiter comes in, oh, nice to see you, just the two of you, is it? Here's a table. Is this okay for you? Would you like a window seat? Drink, yeah, oh, lovely, sure, yeah. Which is the waiter that you're going to tip? It wasn't a very good impression, I acknowledge that, but it's pretty rubbish. I'm not sure I'd tip any of them. But the point is, how much more effort did it take for me to be nice? Nothing. I actually found it harder to be a bit awkward, really. So just think about that. Think about that. That costs absolutely nothing. So being nice works. The other key point, just before I sort of wrap things up, is there's something called self-efficacy, and that is, there's a famous quote by Henry Ford, if you think you can or you think you can't, you're probably right. Now that might sound, yeah, but there is a positive and significant relationship between self-efficacy beliefs of someone, a change agent, and her or his ability to facilitate change. So I'm going to share this with you. I actually believe I can. That's not because I'm overconfident, but I do have an inner belief that a lot of things are possible. Like I have a belief that that patient's time is really, really important. I have an internal belief that motivates me that we can save patients' time. I have an internal belief that makes me feel that on a bigger scale than we're doing now, we can reduce unnecessary waiting. I have an internal belief that waiting isn't passive. I have an internal belief, absolutely, that most people in the NHS are fundamentally brilliant, and we forget that. But the evidence is, if you believe you can, you probably have a chance of doing it. If you believe you can't, you won't. But I think fundamentally, most people believe there's an opportunity. But before I finish, I just want to finish by playing one more video. This is a video, and the poem is the words of a staff nurse called Molly Case, who's she was asked to. This poem was commissioned by Jane Cummings, who's the chief nursing officer for England, and it was commissioned on behalf of Kate Granger. Remember Kate Granger, the brilliant doctor who came up with the Hello, My Name Is campaign? And this film and poem is about the last 1,000 days. So it's just to leave you before we have a discussion around what are we trying to do here. What we're trying to do is save patients time. What we're trying to do is, if you're the last 1,000, you have 1,000 days left to live, how many of those do you truly, really want to wait in a hospital? So just finishing off, I find that video quite powerful, really. It's, you know, if you Google it on YouTube, we've got a YouTube channel, ESIST1, but it's very powerful. I mean, just finishing off is, you know, this stuff, it sounds like you've made you started your journey with the Safer Patient Flow Bundle and Red to Green Days and then PJ paralysis. There's always opportunities, further opportunities for improvement. One of the big things is, you know, is to test stuff out, give it a go, use the improvement approach. You've got an improvement team, you've got the infrastructure, and you know, this is a set of steps. You don't need to see everything before you take your first step. Is to give it a go. What's the worst thing that could happen? So that's me finished speaking. You'll be pleased to know. What would be good is to pick up on, well, maybe a couple of the last comments, which are things that don't make sense or things that we could improve, and then maybe some of your ideas to build on some of the work you've already done, which could be around the Safer Patient Flow Bundle, could be around getting people up and dressed and moving. It could be about reducing the amount of sequential processes and maybe thinking about having parallel processes. What are your thoughts?